University of Science and Technology, and also a member of Ecsaconm. So I'm privileged to chair this session, and this session mainly is on keynote speakers. We are privileged to have 4 main speakers. We have 4 sub-themes that we are going to focus on right now. There's leadership and advocacy, primary healthcare, non-communicable diseases, and workforce retention.
Viva nurses, viva!
Viva!
Viva midwives, viva!
Viva!
Mupo!
Mupo!
Thank you. Okay. So now, my name is Dr. Judith Awinja, as you see, Director Nursing and Midwifery Services, MOH, Nairobi. I arrived yesterday and happy I was invited very positively. So I was told to talk about the significance of leadership, governance, and management in health outcomes. However, I today would wish to talk so much of transformational leadership. This is when we started growing up. I even wrote about 3 books on leadership, management, and governance. Sijui kama mlishawaiona, kama mjaona mniulize nitawapatia. And this was that time. We are really moving so fast on transformational leadership and AI. This is what we need to know, and entrepreneurship as nurses. See at in bedside peke yake. And this is exactly what I think we need to know as nurses. However, since I was given this, let me just go straight into this. And today I was told I should be turning my neck. I don't know why, but these are the outlines which I'll just skip very fast. And I just want to give you a few phrases from our relevant bodies and people who understand about leadership, management, and governance. And we start with WHO, which says leadership sets the strategic vision and mobilizes the efforts towards its realization, while good managers ensure effective organizational utilization of resources to achieve results and meet the aim. And these are the people who guide us in everything that we do about health. So if they have said this, then we need to move ahead. So leadership versus management is that the act of influence and motivating a group of people to act in the same direction towards achieving a common goal is what we call leadership. There are so many versions and many others, whereas management is the process of leading and directing an organizational to meet its goals through the use of appropriate resources. However, transformational leadership changes exactly what you want to do into the performed leadership engaging to the achievement of the present outcome that is coming on tomorrow. Okay? So I prefer we go as transformational leadership more. This is all about leadership and management, everybody giving the phrases of management, which would be good for you when you get the presentation. So, a small introduction is that leadership, governance, and management are foundational pillars that determine the efficiency, effectiveness, and equity of healthcare systems. And their influence directly shapes healthcare outcomes, patient satisfaction, workforce performance, and the achievement of universal health coverage. This is exactly where we are geared to. However, I always say, as I've advocated for, we need to go transformational way because we are now embracing AI. And AI is what we talk about today, every day, and get changes of every kind of leadership or management. So why are we talking about leadership? You can see I've put some, should I say nurses or individuals? I tried to check on nurses because today's world is characterized by rapid changes in technology, now moved to AI, the way I've just told you. And teamwork, as you climb ahead, this is what embraces what transformation and governance and leadership is all about. So we need to move in that direction, and there's a move of diverse workforce changes in government organization, regulations, worldwide competitions, and growing complexity of issues in general, and global warming. So we change, there's so much changes, and that is what has today led from leadership, management, governance to transformational leadership, which makes a lot of change. But leadership, as we all know, It's just setting a direction and aligning teams with the healthcare goals, building resilience health systems, especially during crisis, such as pandemic, promoting equity, ethical. So when we talk about a leader, whom are you talking about? Who is this leader? And I'm just trying to reflect on us as nurses and midwives. What about this leadership? What are we saying leadership is? Because you cannot just manage to do leadership without management, and governance actually is the oversight body. We cannot just do leadership without management. How do we do our leadership? And this is the reason why I keep on saying I didn't write anything about transformation leadership, but that is must always come in front because you are transformed. Nyinyi sasa watu wako Gen Z wengi, AI imeingia, transformational imeingia. I even did a paper the other side on transformation leadership in nursing, which was published just in January. I also went to school just the other day. I finished in January. It was about leadership. The course was post-PhD for 1 year. It was called leadership, executive leadership. But what I saw was just transformational. There was nothing like leadership. They called it leadership. And what was there was transformation. What do we mean by transformation? How do we align ourselves in the vision that we have? This is what we are calling about transformation. We need to align with what is already there, because most of us actually do not understand the policies that we have. We don't understand the strategies that are guiding us, and you will wake up, start making noise before reading what we have in place. And as a leader and a manager, because I know all of you are leaders and managers, telling me 5 minutes, okay. 2 minutes, in fact. So as leaders and managers, you need to understand these policy documents, okay? You need to understand the law. It is very critical. You'll hear somebody coming to tell me, you know, I didn't get my license. Me, I'm at the policy level. I did not get my license and I don't know what to do. You are coming to tell me because you don't understand. Person you need to understand, to ask about license is the CEO Registrar Nursing Council. You get what I mean? And when a nurse comes to ask you and you are the leader in charge of that place, unamwambia enda kwa Dr. Winja, because you don't understand and you don't know what it is. What I'm trying to bring across, you need to understand what your policies and law says about your profession and the work that we are doing currently, including the Constitution. Once you know that, you can be transformed and you teach others to transform. Kwa mfano now, my senior, where she was my mentor, by the way, she could be doing something. She was working, yes, in the nursing fraternity, and then she had something else, a side chat, that was seeing her move further and front. And that way she became the CEO of something. I'm just giving an example, a CEO of an organization, yet she is also doing nursing. That is what we call leadership and entrepreneurship. I'm just trying to bring across that you need to understand to multi-do where you think you can excel and pull others to come on board. I hope I'm making some communication. You don't just be a bedside nurse, okay? You work beyond being a bedside nurse. Engage in so much that will guide you to transform others. I've put here a synergy of LMG, but I'm talking about transformation. So the synergy of LMG says between leadership, governance, and management. Actually, I love this. Thank you. Asante sana, Daktari. So you see, the synergy between leadership, governance, and management creates an enabling environment for improved healthcare outcomes. In contexts like Kenya, investing in these 3 areas is essential to optimize service delivery, enhance patient safety, and progress towards universal health coverage and sustainable development goals. This is one thing that I saw. When you embrace the things, slowly and slowly you graduate into transforming so much. And when you transform, you see a broader picture. And this broader picture is how can I do other things best than what I'm doing today to deliver what I have. And that thinking broad makes you to start as something When you start anything, an organization, when you start anything that is next to you, or a program, that way you are now impressing leadership because you're the one leading that program. Kwa mfano, hii community strategy, I don't know, none of you know, but it is me who brought it in Kenya in 2006, before others were born. In 2006. And that is now leadership. I know you didn't know, but you need to clap for your profession. Ni sisi tuliileta, nursing. I actually went for a training in Japan for 3 months, and that training we were subjected into people's houses. Inyata tujui kunaenda wapi, because we had to understand what is this about community strategy, and we had to go in so many prefectures to do that. That's when I talked to my boss, and she accepted, and we started in 2006. I still have the concept, I still have the documents, and they always consult me. Makofi and nurses, not Judith, but for nurses. So this is the transformation and leadership I'm trying to talk about. When you work, you think, na hii kitu, nikianzisha hivi, sitafanyika, an innovative mind. You start a program. You start something that people will see. You can even start an organization beyond what you are doing. Now that is saying far. This is exactly what I want you to understand, and also understand your policies, as I've told you. So the key challenges, limited leadership roles for nurses at policy level, governance gaps at county level, inadequate managerial skills and tools, and even implementation for national nursing strategies. And me, I think I'm going to start something on transformational leadership. I'm doing a School of Excellency at Strathmore, na muende msome, so that you can change. So there we have opportunities for strengthening is investing in nursing leadership training, e.g. the ICN leadership programs. We have so many in ICN, and we can set off. There was one I had started strengthening, health system strengthening, and it's still moving on up to today. We did with the KSG, still moving on. So when you invest so much in leadership and transformational leadership governance, you will know whenever you are told to go to the Nursing Council board, you know what to do, because that is an oversight, it's a governance. You know what to do. You will not go there and start, ngoje nisikie kwanza Collins ataongeaje, nisikie kama we atasemaje kwanza, because you don't understand. And this is what we want you to know. Just have those things on your fingertips. Mimi utaniuliza swali nikose kuambia. Takuwa kuambia constitution inasema hip section, this section, that section, this. I will tell you, because you come on my desk, they are just there, the policy documents, because you need to understand, okay? So that you know how to move ahead. So in conclusion, leadership, governance, and management are not optional, they are essential, you know? So strong systems elevate nursing practice and health outcomes, and a coordinated approach will advance Kenya's progress toward UHC. This is a nurse mwenye ameona mbali sana. Ameona mbali sana beyond leadership. And he says, if I do this, these nurses will gain this. These nurses will be on a very high scale. These nurses will be able to deliver this. Now what once kuuliza, they come to benchmark on you. What have you done to make this thing work? You get what I mean? This is what we are doing. Asanteni sana, nimeambiwa 2 minutes. Thank you so much.
My name is Felicity Musimbi Ingaduli, a nursing officer based at Hamisi Pen Plus Clinic. I work courtesy of NCD Alliance Kenya. It's an NGO that established the Pen Plus Clinic at Hamisi in collaboration with the county government as well as the Ministry of Health, National Ministry of Health. So I'm privileged to stand in for Mike. It's an honor. You can see my name is surrounded by other very big names. Thank you so much for the opportunity. It's an honor, truly it's an honor. So my name is Felicity. I'm standing in for Mike Endovo. He's the county NCD coordinator. He is supposed to present on non-communicable diseases and mental health, the burden that is curbing our country at the moment. And what are NCDs? Basically, NCDs are the non-communicable diseases in full, which means that the diseases you cannot contact or contract when you live together with one person or transmit from one person to another. And examples, we know the cancers, the breast cancer, colon cancer, prostate cancer, we have the diabetes, we have hypertension, we have sickle cell, we have mental health, chronic respiratory diseases, which are COPD and asthma, as well as other, because there are many. There are very, very many. So when you look at this illustration, every day thousands of Kenyans silently struggle with NCDs, either one NCD or another, either because it is undiagnosed, untreated, or it is poorly managed because of the high costs or limited access to care or insufficient awareness within the community where these patients are. So when you look at this, for example, the percentage of death due to NCDs, globally it is approximately 74%. In Kenya, we are at 39 to 41%. Annual deaths from NCDs, globally we are at 41 to 43 million globally. Kenyan, where he wasn't able to get the clear data, you know that you don't just guess figures. So, and then under the percentage of under 70 years people dying from NCDs, globally we are at approximately 82%. That is in low and middle level income countries. In Kenya, we don't have this data yet captured. Mental health treatment gap. It is there, but you're not getting sufficient treatment. Globally, we are having approximately 76 to 85% in low and middle level income countries, whereas in Kenya, we're approximately at 75%. These are very huge percentage. Then depression global prevalence, we are at approximately 300 million, which is 4.4 globally, and Kenya is ranked among the highest. So why are we having this rapid increase in NCDs? Because we're now getting a shift from the communicable to the non-communicable disease. When you look at, when you look at the illustration, way back, we saw the transformation of human beings. I guess at this point we are consuming, the people are consuming the raw fruits, the wild fruits, the natural foods, unprocessed. But then there's this transformation. You can see the current man, the way he looks. And you look at this body, it is more susceptible to NCDs, the figure itself. You see, the height is increasing. Right now, the state is even going lower and downwards. Look at the consumption of unhealthy diets. We are having fast foods. The fresh foods, we are having fast foods. The ones we get free in the supermarkets. We love buying this for our children. We think we are doing them good by loving them, but we are spoiling their health at that tender age. We are having, I guess this is some beer, some Coke, or is it some alcohol? Coca-Cola. So alcoholic drinks generally, and then we are having here, it may not be so clear, but you look at these carbohydrates, the ugali, carbohydrates. It is fairly healthy, fairly not healthy. Higher. So let's move on. So physical inactivity outcomes. You look at this person sitting there, the cobweb means he has been here for a while, then this other person here. So some of the things that come out of this, you have the depression, type 2 diabetes because of obesity, heart disease, stroke, hypertension, colon cancer, osteoporosis, arthritis, and above all, it's premature death. So the burden of NCDs, we have the direct outpatient costs and we have the hospital costs. Medical supplies, the insulins, the medications, the dialysis, doctors or rather the medical practitioners. Do we have well-trained practitioners take care of these patients? The lab tests. Most of these NCDs, for you to get care, you have to get those baseline tests. For sickle cell, monthly HB, monthly full hemograms. For the ones with renal issues, you have to get the UECs monthly. The same reflects to inpatient care. And then you also have indirect costs, absenteeism from work, disability, and above all, the way I said, premature death. So our focus comes at this Pen Plus Clinic Hamisi. Why am I focusing on this? Because since the launch in June 2023, that was on 19th, in partnership with the NCD Alliance Kenya and MOH, national government and county government, it has become a center of excellence to manage NCDs. And we are linking together with the WHO PEN. PEN was focusing initially on hypertension and diabetes type 2. So PEN Plus is coming in to focus on diabetes type 1, sickle cell disease, chronic respiratory disease, which includes the COPD and asthma, then cardiovascular, and to be specific, rheumatic and congenital heart disease. That's what the clinic is focusing on. So these services, which were primarily before available at tertiary and private institutions, is now available at Hamisi, which is a primary care level facility with highly trained middle level providers. These are the nurses and the clinical officers giving these services to our patients. Guided by the PEN Plus initiative, which seeks to close the gaps in NCD care by decentralizing services from tertiary referral facilities to middle-level community, middle-level services by empowering our middle-level healthcare providers. So it aligns with the broader goal of combating epidemiological transition from the communicable to non-communicable diseases, as I had earlier on stated, while we engage our CHPs and community focal persons for sustainability and implementation. We ensure the clinic that we are giving health education to our patients and all that to attend there to our clients so that we are at par of what is being offered. We have proven protocols and visitations. Once in a while, we have consultants from our VCRH, from Kenyatta, that is for pediatric cardiology, for the cardiovascular cases. We have links also from MTRH to be able to empower us more on managing these conditions. So notably, we have introduced both in-person and virtual trainings in cardiac sonography, that is echo and point of care ECGs. We have been equipping healthcare workers with skills for early detection, especially that is sickle cell and rheumatic heart disease, and diagnosis of cardiovascular diseases, which has significantly expanded the scope and quality of care under CVDs. And this is not just in CVDs, we have spirometry for asthma, as well as other conditions like in type 1. Additionally, we have constant supply of essential medicines. For sickle cell, you have hydroxyurea, PenV, and folic. For type 1, we have the machines, we have the prickers, we have the insulins. For the asthma, we have the inhalers available for our patients. So therefore, we invite stakeholders and other professional and policymakers to be able to put hands together and implement such PEN Plus clinics in other parts of the countries. Currently, there are only two. One in Vihiga, that is in Hamisi, and one in Isiolo at Kina Health Center. So overall, what is our role? During the training of the PEN Plus staffs, the clinical staffs and the nurses, this is what we measure on: health education, promotion, and awareness. The moment you have empowered your nurse, he'll be able to give health education and promote awareness in the community, which will enable now the community to come and seek these services at the clinic. Screening and early detection is very important. The moment you have screened, you've known a patient has sickle cell, has type 1 diabetes, has cardiovascular conditions, you start up early the treatment to avoid complications from setting in and slow down the disease progression. Patient empowerment is very important. NCDs are lifelong. If you don't empower this patient to be positive about themselves and be able to live and even be able to propagate advocacy, this is very important. You may not be able to achieve what you want as a nurse. Then chronic care management and mental support. Mental support is for both the patient and the family. Advocacy and policies. Then coordination and multidisciplinary collaboration, research, that is why we are here, and evidence-based practice. Thank you so much.
Countries, you deliver 90% of the services. So that means you may only refer the 10%. Just reflect, and that statistics make sense. So when we talk about primary health care, what do we refer to? We are referring to the work that you do. You deliver promotive, preventive, curative, rehabilitative and palliative care service. And generally, that's the scope of primary health care. If you talk about the delivery of primary health care services, you also provide emergency care in higher level facilities, in tertiary facilities. You offer delivery services, midwifery services, basic diagnostic services you do offer. I've left out prescription because it's debatable, but you also prescribe in addition to other administrative services that you offer. And as such, you are central in advancing universal health coverage, sustainable development goals. So I'll look at briefly about frameworks. What has been demonstrated that you do, just packing it up so that it makes a bit of sense for us. So these frameworks guide innovation, leadership, and quality care. I think the previous speaker have alluded in some of this, especially on the aspect of leadership, championing for community health services. That's leadership that you have been able to demonstrate. And the previous speakers in service delivery have highlighted the quality of care in the abstract that they have shared. I don't think they were shared by doctors. The early morning session, they were shared by us, the host of this conference. And that's very noble thing that you have done. So you help align, the frameworks help align practice and global standards. They strengthen community health outcomes and professional recognition. So the first framework is primary care nursing model, and in this, nurses are the coordinators of comprehensive and continuous care. Some of the features that are reflected on this model is personalized care plans addressing physical, psychosocial, environmental factors. It emphasizes autonomy and accountability, and that comes on aspect of leadership and governance. Then there is a strong nurse-patient relationship, which you cultivate, especially for you to thrive at a community level where you provide services. So how is this relevant to us? It validates leadership in rural clinics where you manage diverse health needs of our patients. The second model is individualized nursing care model, and this one is patient-centered care tailored to unique needs. It's where you treat a patient as an individual. It's patient-centered, yeah? So you will see Vitalis as Vitalis, coming from a community that lives closer to that dispensary or that health facility. So you have personalized care. Next slide. So in this you have a holistic approach including emotional, holistic approach including emotional, cultural, and social factors, and it empowers patients through education and participation. The relevance of this model is that it builds trust and service uptake in cultural diverse communities. If you are not in a community, patients have to come to you. So you have to understand your community that you serve. And that's the only way that patients or clients will work that facility that you manage. Then the nursing care-led model. Here you have nurses lead clinics, prescribe treatments, and manage cases. And here we have a lot of task shifting, and I think this is the most common that you will say. You have task shifting, you are the physician, you are the lab tech, you are the administrator, you are holistic in brief. Yeah? So the relevance is that it expands access and reduces inequities. And this is the one that is critical for universal health coverage. The WHO also recognizes leadership and governance, what Dr. Judith has talked about. And generally here you are reviewed as that the model strengthens your capacity to lead And that's what the challenge she has said as she advocates for leadership at Strathmore. So it just builds your capacity to lead. And it therefore promotes autonomy and policy engagement. You are able to reach out to the leadership that may be and negotiate and advocate for better service. So it empowers you to be an advocate to the vulnerable population. So whatever you do is appropriate. Then we have scope of practice. This one is defined in our various countries. Of course, we have global scope, but each country defines a scope of what you do. And this is where now we embed issues like task shifting. Yeah, but in essence, it allows you to be comprehensive in delivering promotive and emergency services and the other additional services that may be. How are these frameworks important to us? One is that they promote autonomy, thereby advocating for inclusive policies. They coordinate care. So you have to organize your team. You have to organize referral. Then they deliver culture responsive care, tailor intervention to community traditions. You have to be innovative. Yeah? Issues of telemedicine, telehealth, phone calls, SMSs in delivering services. Then you grow professionally. You have to be a lifelong learner. Then lastly is that they improve quality. So you have to use evidence-based. And that is done through research that we have had the presentations this morning. In conclusion, nurses and midwives are therefore the cornerstones of PHC in Africa. You will not walk away from this. So what you are required to do is innovate. Because if you are the only doctor, clinician, laboratory, nutritionist, you are not a jack of all trades. That's what I usually say. You are comprehensive in nature. Yeah? And therefore, because what you offer is in a framework, it's comparable to any institutions that we are and internationally. So these frameworks empower you to offer high quality health services and leadership. Yeah? Then we are all called to let's champion the models, advocate for enabling policies, and innovate boldly. I'll finish by requesting us, if I'll have allowed us to read, but since we have, I know we have professors here, we have lecturers here, so I'll read for us, so that I don't embarrass myself. So let me read my call to action. Let us arise as architects of change, assistant midwives, who not only care, but lead, innovate, and advocate. Embrace these frameworks as tools of empowerment. Demand policies, reorganize your leadership, deliver care that respects culture, uplifts communities, and transforms systems. The future of health in Africa depends on your voice, your vision, and your unwavering commitment. Thank you.
I wanted somebody who can talk about who is a nurse and who is a midwife, and it has been very well done. Now that I'm going to talk about the nurse and the midwife, an asset that has been given to you, my task is to see how we can attract and retain this good person. Next. I may not be able to want to say distinguished guest excellencies because I was initially told that our ministers and the governors were going to be around, but I'm sure somebody is taking the salute for them. I also want to say that I'm honored to stand before my own colleagues. Right, I will go to just talk about the deficit. It's not merely statistics. It represents unfulfilled prescriptions which my predecessor did not want to talk about, But we know that in the enhanced scope of practice, if the nursing council was here, they would have said, they are there. You can therefore confirm that the nurses we have today are properly trained to see the patient, go through the patient, prescribe the relevant medication with full authority. And there are countries where nurses who have not done that, they are taken back for training on prescription and therapeutics. Finally, we are going to draw from global evidence and regional innovations that I will propose what we need to do to attract and retain. In our country today, when we talk about attracting people to nursing, it is taken for granted. Because there are so many who are yearning to be nurses. Until the nursing council, you are still behind because you are approving 20 students for an institution that is not sustainable. The institution cannot manage, will not make even with the 20 students when help is also not submitting the money. So, and because we are advanced, there are many other ways of training the nurses rather than relying on the actual patient in Ward 6. Now, the reason why we need to attract and retain are as given here before. People have talked about chronic diseases. People have talked about non-communicable diseases. People have talked about maternal neonatal deaths in this country. People have talked about public health issues, issues that are brought about by climate change. And so, we need these people called nurses. Although I said for now, we are having so many of them, but some disease is coming, which is called demographic transition, demographic shift. And we are being told that a country like Kenya, in the next 25 years, and because you do nursing when you pass maths, you can add 25 to your years now, and you find how old you will be. Then we can look at the Gen Zs now. Give them another 25 years. How old are they going to be? After 2050, what you are seeing in Europe and everywhere else, we are going to see it here. It therefore will become very important to attract and retain. I've been shown that my time is gone. That is the disadvantage of giving a professor 10 minutes. So let's just look at the statistics, which I'm not going to read. This is what the statistics are showing. And you can see how much we are below what is recommended by WHO. I still don't want to continue with the statistics, but we can look at the workforce attrition. 40% of our nurses are struggling to go to Europe, to go to America. In fact, that is what is attracting most of the nurses into our training today. Nursing used to be a calling, but now it is no longer a calling for many. It is business as now let us look at the challenges that we need to overcome. And Bwana Minister, I'm looking at you with my two eyes, that you tackle these challenges. One, inadequate money in the pocket. Once upon a time I was a soldier, and we believe that I die with my money in my pocket. I work for money, and I walk on my abdomen. Mr. Minister, if the nurses are not properly remunerated, they will fly to the US. The worst that is happening is that our very best are the ones flying out. And Mr. Minister, you must know that there is a difference between a nurse and a nurse, because a nurse is not just a nurse. The rest we can go through by ourselves. What are the consequences of the flight, of the shortage? The consequences are very serious. If we are in a serious country, but we are in a country that's bubbling with population, and you think human beings, even if one dies, it does not really matter, because there are several. But a time is coming. If you go to Europe and you are a mother and you are pregnant, the day you say you are pregnant, you are given maternity leave, paid by the state. And if you are going to deliver, maybe you are in Mombasa and the only hospital where you can deliver is in Wajir. You will be flown to Wajir and booked in a hotel nearby the hospital for 2 weeks as you wait to deliver. What about Kenya? Then we are talking about burnout. Bwana Minister, I wish you are several, but you will tell the rest. That you go to our facilities and you find the whole facility, as Dr. Harriet said, the nurse is comprehensive. And it's only one nurse. Then it's being called, oh, another patient has come in the maternity unit. We have an emergency. How will you manage? Burnout. And they hear, if you go to Britain, you work a few hours. And every other hour is paid for. All right. I don't want to waste time on that because I was shown time. Let's now go to strategies that we can use to attract. And they are very simple. They are very cheap. The money we lose in this country through corruption is able to recruit enough. What I also want to say is this. When I said, the minister must know who is a nurse and who is a nurse. Not anybody in a white coat is. And I know the problem with our county governments. The money given to them to employ is also restricted from the source. And is told you can only pay so much for salaries. So then, when it comes to employing nurses, they look for anybody who will be in uniform in that ward. And the patient will look around and die like birds. But what is the future? So for us to encourage the next generation to understand that nursing and midwifery, and I think my predecessor made it very well, is not just a job, but a proud, valued, and a rewarding career. That one they already known. And that's why they fly to Europe, Australia, etc. I don't want to waste time on that. So let us look at number 1, career feasibility, which I said we don't need to over-exercise because our people are already educated about it. So these are some of the things you can use if you go to school to attract. They can see where the hospital is, how nurses are working. This is for us, for now, it's not relevant, but it's going to be relevant from after 2050. Even this innovative educational pathways, the professors in the house from the old traditional universities who do not recognize prior learning. I normally give a very bad example by one of our people who became a chief secretary. He was called Simon Nyachai. The history tells us that he left school maybe in Form 2. But by the time he was retiring, he was the chief secretary. If you were to give him a degree, would you give him a Form 2 degree or a PhD in management? The answer is with you. Then we need flexible learning, online learning, etc. Let me move faster. This one is, we need to recruit from every community, including the pastoral communities, hard to reach areas. I have a story to tell, even if my time is up. And the story is this. Once upon a time, I was a dean of some school with somebody here. And a student from Narok, you know the people who live in Narok, he just applied to come to do nursing in Masinde Muliro. But he never got admission letter. The day we were opening, he came with the whole village. They traveled in the evening, they slept in the bus stop. In the morning, they were the first people to reach the university. Then he's told, give us your admission letter. He didn't have. Then he said, I came because I applied, I have the money, and I met the qualifications. Yes, then I say, because me, I do abnormal things. I say, even if the nursing council were going to bypass by one student, if they want to sack me, they can sack me. So we admitted the student that I was told he has no admission letter. I said, yes, we can process the admission letter, but in the meantime, I will tell the parents to look for accommodation where the guy is going to stay, and they could go back knowing very well that their child is admitted. On retention, I think, retention, yes. There are so many things that we can do about retention. One is, when I talk about well-being and safety of our nurses, when we had COVID-19, the people who died most, the healthcare providers, were nurses. I was one of them leading the team because everybody else got scared. And I was also admitted with COVID. I almost died. And the people who refused said, yes, that's why we refused. But I survived because God wanted me to survive. So well-being of the nurses. We look at the so-called risk allowance. It is paid on what basis? On the degree of risk. Is it? So it should be based on the degree of risk. A guy who just walks in the ward and says, yes, how many patients do you have? 6 of them. He gets the highest, but the fellow who is touching the patient with a communicable disease is the nurse and gets least. So the rest can follow. All this can follow because my time is up, and it is said, Professor can also give homework. I'll give you homework. Please read, do the assignment, and make sure you don't do a supplementary. Thank you.